Good evening, ladies and gentlemen. Uh, Thank you, organization, to inviting me to talk on key highlights in managing refractory relapse multiple myeloma. This is disclaimer, and I have no disclosure. So, in next 15 to 20 minutes, based on what was update in 2021, I will take you five agenda. First, eye-opening question, then latest updates based on IMWG, ESMO, and NCCN guideline in both lean exposed and lean refractory multiple myeloma and the background research data. Then roll off DARA-KT in lean exposed and lean refractory based on the Candor trial, and real world experience how I treat my patient in multiple myeloma hits of A to G. And then my question, how do you predict for KD based regimen in 2022? And then your question and answer. So this is just eye opener. Which guideline you use to treat multiple myeloma? Of course, everyone use 1 out of 4, but what we do, we use NCCN guideline in our center. So first, as our topic is relapsed refractory multiple myeloma, we'll go by definition. So what is the refractory myeloma? Refractory myeloma, the disease not response while on therapy or progress within 60 days of the therapy. So we label these patients as a refractory myeloma. And other than this, we call as a relapsed myeloma. It means the people who don't have fit to refractory myeloma definition, other than we call as a relapsed myeloma. Now we go one by one. First is the ESMO, which is update in 2021, the ESMO guideline. What ESMO guidelines say about the first line of therapy? So eligibility is the first thing is first for autologous transplant. If they are not eligible, they will go by DARA RD or DARA VMP. If these are not available, people will go VMP and RD. If patient is eligible for autologous, then induction chemotherapy, here they use actually again VRD or DARA VTT. If these are options not available, then the cost effective is the VCT and VTT, and then followed by high dose chemotherapy and autologous transplant, then lenalidomide maintenance. Now, the people who have relapse, there is second line option after VRD and second line option after DARA RD and second line option after DARA VTT. So this is common sense. The people who have lean sensitive, they will able to again get lenalidomide. The people who have lenalidomide refractory, which I mentioned definition, on treatment or within 60 days, disease progress, we call it lean refractory. Here, lean will be out. So similarly, with the Velcade, with same, and similarly, RVD refractory means any person who is RVD and disease progress during RVD, we call as is refractory to RVD. So the option left is DARA-KD and ISA-KD. So this is a common sense. First thing is first you have to define whether this is a refractory or relapse. Then you choose multiple of choice. You can see here. Now, second or subsequent relapse. Again, same. You can see here the people who have lenalidomide and bertuzumab refractory. Then these two drugs will be out. Then rest is left like DARA-KD, ISA-PD, and like ISA-KD. Similarly here, if depending on the pertuzumab sensitive and different option, so you will go accordingly. So this is ESMO. Now, second thing is NCCN guideline. NCCN guideline, this is the new version for version 5 of 2022. So this is the first line. Again, the patient who are eligible for transplant, the treatment is RVD, but in some circumstances, when patient is high risk disease, you can choose also KRD or DARA RVD So these are the options, and then maintenance is again same, lenalidomide. So these are the things. And then again, the patients who are not transplant, so what are the treatment option? Here is again VRD or DARA RD, or you can use KRD as well. So these are the options for the patient who not transplant. And the people who have relapse or refractory disease, again, there are options based on the choice. You have to see your patient is whether refractory or relapse, then you can find out of these guidelines. Now, third is International Myeloma Working Group. What they say, again, there is no difference. If you go by first relapse, again, they divide not refractory to lenalidomide or refractory to lenalidomide. So, you can say the basic thing is, first thing is you have to find out it is refractory or relapse. Based on, you can choose the regimen. Actually, why these put in the guideline? This is, if you go in depth of clinical data update, you can see here, like Enjoy trial, which is based on the 900 patient, they have shown that KD has survival benefit 50% higher as compared to the VD. And similarly here, Kender-West trial, they have shows like DARA KD has shown benefit of 40% higher than the simply KD. Similarly in ACMA trial as well. So it means you can see, you can choose what is the benefit and you can do accordingly. Similarly here, all the bunch of the options are Aspire trial, ENCOAS trial, Kester trial, Booston trial, all, you have can see 30 to 40% benefit if you go from doublet to triplet treatment. Now, if you go furthermore in deep of the key research of the meta-analysis of lenalidomide patients, so here you can see, this is meta-analysis. You can see here two groups here, lean refractory and lean exposed patients. You see lean refractory, who is favoring the treatment, favoring is again DARA VD, DARA KD, DARA PVD. You can say naturally there is no lenalidomide. So, based on this, they put in a guideline. Here you see lean previously exposed. Here you can see there are some patients, they can get advantage of lenalidomide as well. So this is the big meta-analysis. And the important thing which I wanted to show why Kender trial we are focusing more, because here you say 80%, which is the highest 80%, which are actually lean refractory patient. This is very high number of patients as compared to the other trials. So now we'll go to Kender trial. Kender trial is basically more than 450 patients and 2-to-1 randomized. The standard treatment was KD, and then experimental was just edited daratumumab with the same protocol, and then it will continue till disease progress. Here you can benefit. This is the KDD, a clear choice of rapid and deeper response, prolonged PFS. You can say, you can put two finger in this. Here is median PFS 15.8, and in DARA KD, it is still not reached. And hazard ratio is 0.46. It means about 54% benefit of the PFS if you add DARA with the KD. And similarly, deeper response, which is called as a here you can say MRD. MRD means a 10-5 threshold, which is 13%, which we can say it is up to the level of the cure potential. So this is a huge number with the DARA KD who are exposed to the lean refractory. See, lenalidomide exposed patient, 47% risk reduction, and lenalidomide refractory patient, about 53% reduction. So this is the huge number of the patient. So similarly, as I mentioned, Enjoy trial. Enjoy trial is basically two, KD versus VD. Both are same, KD versus VD, but the benefit is huge. If you see 5.6 month more benefit and hazard ratio is 0.69. So KD has given benefit of 31% here. And even you see lean refractory, they have given 20% benefit KD as compared to the VD. So based on this, you have seen DARA KD or KD, they are based on the Kender and Enjoy trial, they have given huge difference in heavily treatment patient. Now, going to the real world practice, what we do, What I do, I remember always in chronic disease, it hits of A to G. So what is A? A means accurate diagnosis, and B, before bringing treatment, you have to check indication, choice of therapy with the least drug toxicity, see the efficacy by MRD if you're available, or you can check, immunoglobulin level and feasibility in future. And then finally, how I treat, I will show you. Now I go by two cases. Case one is 67-year. It was in 2021 mid. He came to us with the history of Beckett with the 3 month. He has no other symptom. He has comorbid of hypertension. He is a retired man. On physical exam, he has very high pain from 6 to 7 score out of 10. CBC was normal. X-ray was showing lytic lesion. And these are the labs you can see here. If you go by, multiple myeloma, SLIM and CRAB score, you have to, or IS score, revised IS score. I remember as A, B, C, D. A means albumin. Albumin is low. B means beta macroglobin. This is high. And C means cytogenetics. You can see cytogenetics is also is high risk here. And D mean again LDH is high. So it's actually, you can say in this patient has IgA, kappa, multiple myeloma, stage 3, high risk stage 3B, you can say, because renal creatinine is also slightly high normal. So this is how, before beginning, you can say there is indication. Yes, there is indication of the treatment. So this is how we use as a CRAB, and this is we use SLIM to decide whether patient will take for chemotherapy or not. So definitely this will take the chemotherapy based on this. After A and B, then there is C, choice of therapy, wisely choice of therapy. So again, the target is you have to see. Important thing is cytogenetics. As I mentioned, my patient is high risk cytogenetics, and important thing is you have to see what is your target. Your target is this heavy person, or your target is small one like follicular lymphoma type of multiple myeloma, or ALL type of multiple myeloma. And my patient was target was actually this one. So now, choice of therapy, discuss about this case, this patient. First thing is you have to check eligibility. High risk patient, performance status 0 to 1. Yes, this patient is definite eligible for transplant. So then D for drugs. We are in 2021. So which regimen you will select? You have VRD, KRD, DARA, RVD. Actually, no doubt, as per all the guidelines you have seen, ESMO, NCCN, IMW, so all they are saying VRD is the best. And if in good circumstances, you can use KRD and DARA RVD as well. So like in this patient is high risk, I would choose either quadruplet or KRD, but we have not access as a first line our hospital. So we have VRD first as a first line. This is our hospital protocol to all patients. So we give this patient to VRD. So again, drug decision, I always like to put question 5, like expert online. These are the 5 experts of multiple myeloma: Shaji, Carol, and Peter, Saga. It's very well known. So what they say about my patient, they say you have to choose RVD or DARA RVD based chemotherapy. So we know all these things, you based on the guideline. So anyway, this patient, as I mentioned, he has very severe backache. So he first took radiation therapy for a few days in 20 grays. And then after finishing radiotherapy, we started actually VRD based chemotherapy, which is SOAG S0777. He actually respond very nicely, but you can say after 3 cycle, disease progress clinically and blood tests and chemical, you can say MRI, because he has severe again backache. This is the after RVD cycle, and what they show compression, so new compressive lesions and higher going to IgG, and patient develop anemia. So it means something. VRD. I would define this patient as VRD refractory. You remember, as I mentioned, refractory means on chemotherapy, patient disease progress. So this is VRD refractory. So now the best trial for this patient, as I mentioned, in DARA-KD, we use it. And you can see the beauty of the DARA-KD, which is Kender-based trial. You can say IgG has went down, and clinically patient is doing very great. So now he has received 3 cycle of DARA-KD and now eligible for going to high dose chemotherapy. So this is the journey of the patient. Initially, you can see SWOG, S0777, then disease progress, refractory to RVT. Then we started the DARA KD-based chemotherapy. Similarly, here the kappa is showing same. This is the whole journey of the patient. So similarly, case 2 is also a 62-year lady who was referred from some other hospital. She has severe backache and she underwent actually vertebroplasty in March 2021. And they found in the biopsy it is myeloma. And we did all the workup and we found she has stage 3 multiple myeloma. So she actually, similarly, our protocol is RVD based on the SWOG protocol. We give it again after 4 cycle. She also found refractory to disease. So she was given again Kender-based chemotherapy. Now after 2 cycle of Kender-based chemotherapy, she is in complete remission. So she is also going for transplant. This is the journey of my second patient. You can see first is the RVD, and then disease progress. I started Kender-based chemotherapy. Now, in the last 15 minutes, what I spoke some introductory and opening question. And the important thing, I latest update based on the NMA, IMWG, ESMO, and NCCN guideline. 4 guidelines I mentioned in lean exposed and lean refractory. You have noticed important thing is that you have to see whether the refractory are exposed. Then you decide almost all guidelines recommended similarly. And other thing which I mentioned, DARA KD exposed, which is based on the Kender trial, is a huge difference, and which I shown in my patient as well. And how I treat hits after A to G of the patient, which I shown. So my question is, how do you predict KD management 2022 in your practice? So thank you very much. I am here. We can discuss any question as well. Thank you very much.